Hello, my name is Satyajit. I'm professor of HIV medicine and a consultant physician in a teaching hospital in UK. I'm going to present few cases from the files of my medical grand round. In this video, I will present the case and share with you the available results and like to know from you what do you think could be the possible diagnosis. I will present another video where I will discuss the diagnosis and the management and few salient learning points. I'm sure you may have seen this kind of cases several times in your clinical practice or read from other journals or books or any meetings. This is just one of them which I have encountered with recently. Let's sit back, relax and enjoy the case. A 59-year-old female, born and brought up in UK, known diabetic, type 2, has never taken diabetes seriously. Obviously, it is poorly controlled. She also suffers from high blood pressure and chronic obstructive pulmonary disease, COPD. She presented with worsening shortness of breath for 4 days in this winter, with fever, chest pain, runny nose, sore throat, productive cough with hemoptysis and diarrhea, which is settling now. Her husband had runny nose 1 week ago and a flu-like illness. She has no history of night sweats or weight loss or history of travel abroad in the last 2 years. She smokes cigarette for the last 40 years. She drinks alcohol occasionally and denies of using any illicit drugs. On examination, the patient is conscious and alert. She is tachycardic. Her pulse is irregular and the blood pressure is 110 by 60 mm mercury. She is tachypneic with a respiratory rate of 32 per minute. Her oxygen saturation on pulse oximetry is 89% on air. On examination of the chest, there were wheezes present bilaterally and it was scattered with diminished air entry on the right base. Heart sounds were normal. There was no audible murmurs. Her abdomen was soft. Liver and spleen were not palpable and the bowel sounds were normal. She did not have any focal neurological deficit. A routine set of blood tests were done and I am just mentioning the important ones which might be helpful in this particular case. She had impaired renal function with serum creatinine over 130. Liver function test ALT was raised, but other enzymes and serum bilirubin and albumin were within normal range. Hemoglobin was within normal range, but she has leukocytosis. CRP was raised. Serum ferritin was raised. ESR was just above normal. Serum lactate was raised. Troponin T was raised. Antinuclear antibody was positive. Antinuclear cytoplasmic autoantibody or ANCA was positive, and the subtypes and their levels were waiting. Blood glucose was abnormally raised and HbA1c was raised as well, suggesting poor diabetic control. Several samples were sent for infection screen. Urine dipstick test showed 2+ protein, 3+ glucose and no trace of ketones. A real-time polymerase chain reaction PCR assay performed on a nasopharyngeal swab specimen and it was negative for COVID, and another sample has been sent for confirmation. Acid-fast bacilli smears from 3 bronchial endotracheal specimens were negative, and blood culture, respiratory culture with gram staining and a respiratory viral screening, urine culture are waiting. A CT chest was performed and you can see there is area of consolidation on the right side and also there is small patchy consolidation in other parts of the lung. 12-lead ECG with rhythm strip showing patient has atrial fibrillation and there is a diffuse elevation of ST segments in almost all the leads. A transthoracic echocardiogram was performed and there was diminished ejection fraction of 45%. And there was global thickening of the left ventricle and there was a small fluid in the pericardium. So here is the summary of the case. A 59-year-old female non-diabetic, hypertensive and COPD patient, smoking cigarettes for last 40 years, presenting with fever, progressive shortness of breath, chest pain and diarrhea. She was hypoxic, tachycardic, tachypneic. She had impaired renal function and impaired liver function test with raised ALT, raised inflammatory markers including leukocytosis, and ESR was just above normal. She has raised lactate and troponin T, and she was positive for anti-nuclear antibody and anti-nuclear cytoplasmic autoantibody. Her diabetes was poorly controlled in the form of raised HbA1c and random blood sugar level, CT chest showing evidence of consolidation, ECG showing atrial fibrillation with gross ST changes, and echocardiogram showing impaired ejection fraction with small pericardial effusion. Her COVID test has been negative so far, and the other infection screen results are waiting. So with this information, would it be possible to have a guess about the diagnosis? Could this be influenza with secondary bacterial pneumonia? Could this be pulmonary tuberculosis with pericardial effusion or bronchogenic carcinoma? Pulmonary embolism with pulmonary infarction or myocardial infarction with pneumonia? Or could this be granulomatosis with polyangiitis, which previously we used to call Wagner's granulomatosis? Or could this still be COVID illness or any other conditions? Please share your view, a possible diagnosis, in the comment section, and I'm going to prepare another video where I will discuss the diagnosis and how this case was managed and some learning points. You may subscribe this channel and press the bell icon so that you will be notified when the next video will be published. Keep thinking. Thank you.